So I'm going to talk about the natural history study for PKAN that we've been doing at OHSU for about 5 years now. And my goal is not to dig into the data too much because we haven't done that too much. We're collecting. We haven't done a lot of formal assessment at this point, but I want to give you the 10,000 foot view of what our goals are for the study, what our design is, and how we've been moving forward with that. And I probably should have started with good morning because it is morning for me. And I'll run you through this hopefully in about 7 minutes. So just to touch briefly, because Ivan already did this, but natural history is the natural course of a disease from immediately prior to its inception, progressing through different stages to a final endpoint. And he nicely pointed out for us that, you know, while it would be great to monitor natural history without external intervention, that just doesn't happen in PKAN. People are taking medications, they're adjusting medications, they're getting DBS, they're going to physical therapy. So we are doing the best we can, realizing that there are interventions happening that could also explain different effects in the data. But still, we persist because natural history is key for identifying outcome measures for clinical trials. In the US, it's very important, and the FDA makes that a requirement in most cases. So when we decided to do a natural history study for PKAN, we considered whether it should be a retrospective study or a prospective study and weighed the pros and cons of that. A retrospective study is nice because you can dive back 10 or 20 years by doing chart review. You can compress your timeline and perhaps be more efficient, but the data is inconsistent. The MRIs are all done on different machines. The labs are done in different locations with different ranges. It can make things a little messy. Whereas a prospective study, while intensive and lengthy, allows you to have more control. So, because PKAN is an ultra rare disease and we kind of get what we get and don't get to be too choosy, we decided to do a little bit of both. So our study has sort of an initial visit that includes collection of retrospective data, but then it marches forward with visits every 6 months and collects things prospectively. So this is just an overview of what that looks like, and then I'll go into more detail in the next few slides. But we do take all comers diagnosed with PKAN. We do require that they meet certain inclusion criteria, meaning they either have 2 pathogenic or likely pathogenic mutations, or they have 1 or no mutations plus, an eye of the tiger sign and other clinical findings that we've reviewed ourselves. So we feel confident that everybody in this cohort does indeed have PKAN. And then we do 2 sort of groups of measurements. One is a set of patient-reported outcome measurements, and then the other is a set of PKAN-specific milestones that we've developed ourselves. And I'll explain those in a moment. Also for younger people with PKAN, I believe 10 and younger, we do try to collect retrospective, in most cases, developmental milestone data. And we do try to confirm key milestones with medical records, which is easier for the subjects in the US. It starts to get a little tricky for people in other countries. So we collect serial data every 6 months. This is a completely remote study. Nobody comes to Portland, Oregon, because that would be very expensive, and we think it's more efficient, and we found different ways to do this remotely. And it was actually a nice way to test out some of the remote things we wanted to do before launching the COAZ clinical trial, which is also done remotely, which Dr. Hogarth will talk about next. So every 6 months we collect data. That could be done electronically, by phone, or even on paper in some instances. It really depends on what's best for the subject and where the subject is located. I'll give you an example. For paper, we actually have an Amish cohort in the US, and this is a culture that does not use electricity, modern conveniences, so everything is done by good old US mail and paper, and sometimes a phone that they're using that they can access somewhere. We've also built in an option because we thought it was important and because families felt strongly about this. where the parent of a deceased child can do a single visit and be their proxy, and we can collect retrospective data at least that way in a single visit. So the initial retrospective entry is collected. This, for example, might be collection of Pecan milestones, such as, when did you first start falling or have problems chewing, where if they say, yes, I had that 3 years ago, we collect that date. But then moving forward, we continue to ask questions that they have not reached yet for milestones. The Pecan milestones that we developed cover a broad range of Pecan-specific findings, such as prescription of their first medication for motor symptoms, or first wheelchair use, or when they moved to using a wheelchair full time, G-tube placement, speech changes, eating difficulty. And 5 years ago, we developed these milestones based on our deep experience with Pecan. They were also pulled from some common data elements when possible. We did seek input from other Pecan experts, and we piloted them with families before starting. And then we have adjusted them as needed. For example, we've added some questions along the way that have become more important. One of those being, for example, use of cannabis products like CBD oil or marijuana products, which has become more popular recently. So we also look at a set of patient-reported outcome measures, or what I sometimes call parent-reported outcome measures, because for the little kids, it really is more often the parents answering. For some adults with Pecan who can do this online or on paper, or even some children in the 8 to 17 range with higher function, they can answer these questions themselves. We're using tools that were normed in large populations across a broad age range. That was our goal, because the spectrum in Pecan is so broad. We've tried to choose tools like NIH Toolbox, NeuroQual, or what we call PROMIS, where they've been normed across ages 3 to 85. Granted, there are different sets of questionnaires for some of those age groups broken down, but you can compare them all. And these patient-reported outcome measures cover a broad range that we determined was important, including mobility, pain, motor function, peer relations, anxiety, depression, anger, fatigue, stigma, and activities of daily living. Statistical analysis. This is not my area of expertise. We have partnered with somebody because of the model that we're using, but I can give you a simplistic overview of this part, which I did at the meeting here 3 years ago as well, but now we've actually done some of it. So our plan all along was to use latent growth models, or LGM. This is also called latent growth curves, where the curves model disease progression. So this kind of model has been used in education research a lot, some caregiver research, and some limited studies of MS and Parkinson's. But it's a model that allows us to examine different rates and patterns of disease progression at both a group level and an individual level. So this is just an example of what that might look like. So on the left are 4 different subjects over time, and you can see they each have their own personal line of progression for disease. So I think of this as a growth curve, like a height or a weight curve that you would use for a child over time, where you know what's expected or where the 50% mark is, but you also mark your own patient along their specific line. And what's different is, instead of having only one factor, such as height or weight, the modeling allows you to put in many key factors, so several of those Pecan milestones that you think are important. And so on the left, you can imagine if you had an intervention at time 3, how those lines could potentially change or not. And then on the right, we have an example of how you can also, in aggregate, average data over several subjects to create an expected trajectory and then compare individuals to that. So because this was our first natural history study, we have 3 running right now. We're going to discuss all 3 at different points in this meeting, but this was the first. We started it in 2015, so we're sort of the furthest along, and we've learned the most from it about what to do differently in the other studies. We did do a feasibility study in December 2017, with our collaborator, that's Dr. Brian French and his team at Washington State University here in the US. And this was a feasibility study to assess whether LGM really could be used with the data set that we were developing at the time. We were 2 years in. So we provided a subset of data. At that time, we decided to pull 9 individuals, and we looked at 5 time points. So again, you know, they're doing visits every 6 months, and we limited it to motor and cognitive domains. So it's basically a subset of the data that we were collecting. And Washington State used that data to build models to reflect what's expected in practice. So this is a 20-page report that I'm basically summing up in one bullet point at the bottom. But what they found was that the findings supported that LGM can be used to track disease progression in the PKAN data that we're collecting. And you know, they ran several different models and had different recommendations about if you have a sample of this size, you need at least this many visits, and that sort of thing. But you know, the bottom line was that they recommended a sample of at least 60 subjects and at least greater than 5 time points.
Sorry, so, I have to interrupt. Can you move it on? We're out of time.
Yep, I'm on my last slide. So we have 121 subjects enrolled, and that's oddly the same exact number that I think Ivan said they have in TIRCON, but they're not all the same subjects. 80 are from the US, 41 are international from individual countries and smaller cohorts. And as far as the visits go, we have 81 subjects with 5 or more at those 6-month intervals. We have 40 subjects with fewer than 4. Of those 40, 17 are those single deceased visits that I mentioned. And I no longer have control of my slideshow. There we go. I had conclusions. I guess the bottom line here is, since we're out of time, we have extended this study beyond the 5 years. We're continuing to collect data, and it is a prerequisite to be in this study, to be in the COAZ safety and tolerability trials. So we are collecting this data in parallel with that data as well. Thank you.
Thank you, Allison. I'm afraid that we won't be able to take questions, but I'm sure Allison will be happy to answer the questions online.